Okay, welcome to Cholangio-Hepatocellular Carcinoma Canada's webinar today. We are fortunate to have a prominent physician from Halifax address precision oncology or precision medicine in oncology, specifically biliary tract cancers. Before we start, please put your questions in the chat box and we will answer them after the presentation. Dr. Ramjeesingh holds an MD and a PhD from the University of Toronto. He is a medical oncologist and associate professor. He is the chair of the Hepatopancreatic Cancer Disease Site Group in Halifax. He's the medical director of the Atlantic Clinical Cancer Research Unit and the medical director of the Atlantic Clinical Trials Network Oncology. Dr. Ramjeesingh works at Dalhousie University. He focuses his clinical practice on the treatment of breast cancer, gastrointestinal cancers, including hepatocellular carcinoma, pancreatic, cholangiocarcinoma, and melanoma. His primary research interests include transitional and health services research, as well as oncology education for residents and medical students. On a personal note, I have had the privilege of meeting Dr. Ramjeesingh, and he's very knowledgeable and a very approachable person. He has authored many papers on his interest topics. His topic today is the opportunity of precision medicine in biliary tract cancers. Welcome, Dr. Ramjeesingh.
Thanks, Brenda. I don't know about my knowledgeability, but thank you so much. So thanks everyone for having me. I love talking about precision medicine. I've been treating hepatobiliary tumors for about a decade now. And this actually entered the fray in pancreatic cancer, which has really helped change things for pancreatic cancer. And it's definitely helping biliary tract cancer. So love speaking about biliary tract cancers. And so we'll just kind of move on. Let's just, there you go. Perfect. Okay, so these are my disclosures. Oops. So I always like to do presentations with like an initial case, because just to kind of get everyone on the same page and just talk about biliary tract cancers. So this is a 53-year-old gentleman, JPM. He had a 1-week history of painless jaundice, preceding with a 1-month history of abdominal pain, presented to emerge in July of 2023. Not really much of any kind of medical history. Family history was only remarkable. Mother had breast cancer. And so he underwent a CT scan of his abdomen and pelvis. And I mean, scans are hard to read for most physicians, including patients, but we rely a lot on the reports. And what we were able to see is that there was a 2.3 centimeter mass around just outside the pancreatic head by the duct and with extension up the distal common bile duct. And there was at least 6 small low-density hepatic lesions throughout the liver. Now they're small, they're up to 9 millimeters or close to 1 centimeter. Perspective, my fingertip, which you can't see because of my background, is 2.5 centimeters. So it's about less than half the size of my fingertip. So not very big. So, exam of the patient was normal. They did have a CA19-9, which was elevated, and they underwent an ERCP, which is where they go in, do a scope, and they put a little scope into the bile duct to try to open it up, and they'll sometimes put a slinky in to kind of help things up. And while they're there, they'll take a brush and kind of scrape out some of the tissue to see if they can get a diagnosis. Common bile duct brushings aren't the best thing in the world because, think about it. If you take your toothbrush on the inside of your mouth and scrape that, you don't really get a lot of stuff. So sometimes it's not the best. And so this kind of said maybe there's something there, cancerous, as well. And they had a CT chest which was negative. And so with the CT scan, with the brushings that said maybe it's cancer, and with the CA19-9 being up, we thought this was a biliary tract cancer. So we, at the time, had the new durvalumab combination with chemotherapy available. And so we started them on the combination. They had the combination 8 cycles cisplatin gemcitabine with durvalumab, and then 4 more cycles of the maintenance immunotherapy. And this is what their CA19-9 did. So remember, it was around 4,800, and it just dropped like a rock, which is what you want to see when you're treating patients. And so, scans in March said, well, the mass that was in this pancreobiliary junction was not really seen very well anymore. And also the spots in the liver vanished. Didn't know where they went. So, one of the good things about treating this is you get to interact with surgeons a lot. And sometimes you can walk into the surgeons and say, "Hey, can you look at this and see what you think about this?" And so I actually was able to convince the surgeons to take this patient in for surgery, and they actually did a Whipple's. And what they did find is when they looked at the pathology, that the disease had completely vanished. It was completely responded to the treatment. There was nothing. They also did a wedge resection of the liver just because that's where the spots were. And again, that was all, everything responded. So it was a complete response, which was yay, fabulous. And so this means that we've been following this person since then and still no evidence of disease. So, sometimes you have some really amazing outcomes with treatment. So, now that I've wet your whistle of biliary tract cancer, let's talk about this. So, the biliary tract system, it's part of our digestive system. It has bile ducts, it has gallbladder, and really its primary focus is to drain waste products from the liver into the duodenum. It helps with digestion by secreting the bile, which helps with digestion. And our gallbladder is this little reserve of bile, so it spits out the bile when we have something to eat where it needs to have digestion. So when we look at the bile duct, it's produced in the left-right portions of the liver, the bile, sorry, and it travels through the right and left hepatic ducts. These ducts then will merge into the common hepatoduct, which will then union with the common hepatic duct and cystic ducts to form the common bile duct. And this will then enter in at the head of the pancreas, and that's kind of where we call the ampular evader. So this is just the anatomy of it all. And so cancer can occur anywhere. When it happens in the bile ducts, it's called biliary tract cancer. It is actually technically a basket term because these are cancers that differ by location, genomic expression, and etiologies. So there are intrahepatic in the liver, cholangiocarcinomas, which are in the liver. Then you can have distal cholangiocarcinomas. These are outside the liver. And then there's these hilar cholangiocarcinomas, which are like right here, right underneath the liver. And then you have the gallbladder cancer. So historically, we used to call this all biliary tract cancers, and they're all treated the same. And more and more realize these are different diseases, and I'll talk about that in a second. But again, we look at them as intrahepatic, extrahepatic, gallbladder, and within the extrahepatic, we look further subdividing with perihilar and distal. So when we look at the expression level of biliary tract cancers, majority tends to be in this perihilar, just underneath the liver, which is about 50% of them. About 20% tend to be intrahepatic cholangiocarcinomas, and the rest are these distals. Within the intrahepatics, you can have what we call flat. So they're like just right on the ducts, and you really can't see them. They're just very flat. Or you can have a mass forming as well. So it forms a mass as well. So we have periductal infiltrative, we can have ducts, we can have masses. So there's a whole bunch of different variations of these cholangiocarcinomas. And so we know, based in the epidemiology, it accounts for about 3% of all the GI tumors. And so that's like upper GI, esophagus, colon, pancreas, like everything when you think about it. It's the most common biliary malignancy. It's about 10 to 20% of the hepatic cancers as well. And, the incidence in Canada, they say is 0.35 over 100,000. When you work that out, though, according to that, and this is data from, 2015 or so, 0.35 per 100,000. If you assume we have a population of 39 million, which suggests we have 138 cases per year in Canada, which is wrong. We all know that. Those numbers don't make any sense whatsoever. I see 20 to 30 a year myself. I can't be in person in Halifax seeing 30% of the Canadian population. So we know these numbers are wrong. Okay. So I'm going to talk a little bit about liver cancer, and there's a reason why I'm talking about this, and I'll kind of unveil that a little bit later. But when we look at liver cancer, which includes the intrahepatic cholangiocarcinomas, we know that there's more in men than in women. In Canada, we expect liver cancer is about 4,750. And they say, intrahepatics are about 4% of that population. There's more data that says we are at 2.35 cases per 100,000. If you assume back our population 39 million, there's about 936 cases. That seems way more realistic than 135. So that's kind of what we're thinking of the number of cases in Canada. And this is the breakdown when you look at it by province. And so you expect like BC will have 750, Alberta 450, Ontario 1,500. No, but these are liver cancer, which includes the intrahepatics as well. Nova Scotia, we see about 130 as well. Now, one of the things I like to do is play around with data. I like numbers. And so when you start to normalize the rates across Canada, you start to see that some places have higher rates of liver cancer and some places have lower rates of liver cancer. So BC, Quebec, Nova Scotia have higher rates of liver cancer than the standard Canadian national average, and the rest of Canada has slightly lower rates. Why? No idea. No one has an idea of why the rates are different as well, though I have suspicions. But we don't have a clear reason why the rates are different. We do know the rate of liver cancer is increasing in Canada, and this is whether you look at men or women. When you add it here, it's all increasing over time, and this is data from the Canadian Cancer Society. We also know that the rates of liver cancer incidence in Canada and the US in the younger population, that's age 20 to 39, is also increasing over time. So we're seeing younger people having higher rates of liver cancer. Now, I keep talking about liver cancer. Why am I not talking about biliary tract cancer? The reason is the Canadian Cancer Society doesn't track it, and that's a problem. So all our data is based on the Canadian Cancer Society. And so when you look at it, intrahepatic cholangiocarcinomas or bile duct cancers are lumped under liver. So they're coded 22. Everything else, extrahepatic, ampullary, biliary tract, not yet diagnosed gallbladder cancers, are all considered other. So they're all part of the other category of cancers. So we actually have no idea what are the numbers of biliary tract cancer in Canada because no one's tracking it. So sometimes we then rely on something called real-world evidence. So people who look at the number of cases in their jurisdiction to say, this is how many cases we have. Again, it's not the best in the sense of not having a national registry like the Canadian Cancer Society does, but this does give you a little bit of idea of what's going on. And so there is real-world evidence published from Ontario and BC. We have some from Nova Scotia that's not published. There is stuff from Saskatchewan that's published, but it's behind a paywall that none of us can access. So I can't say anything about Saskatchewan. But we know from the BC data that we're looking at the numbers, you can see the trend is increasing over time, whether you look at intrahepatic, gallbladder, or extrahepatic. So they're increasing over time. And the numbers, you can see how many they're seeing per year. It's a reasonable number. It's not a small number of cancer patients. This is the Halifax experience. And again, we see about 64 biliary tract cancer patients per year on average. So again, not a small number of patients. So again, as I said, I like to play with numbers. So when you can start comparing British Columbia versus Ontario versus Nova Scotia, so BC over a 15-year period saw 1,500 biliary tract patients. Ontario, 2,142 over 10 years. Nova Scotia, we saw 643. When you start to normalize that based on our populations in those provinces, it works out that in BC, they see about 2.1 cases per 100,000. Ontario, you see 1.5 cases per 100,000. Nova Scotia, we see 6.8. So we're 3 times the higher rate in Nova Scotia than Ontario or BC. Do we have any reason why? No, we're not sure. Though I suspect it's the genomics as well. But that's where our data is at right now, is that we're seeing higher rates in certain areas. And I'll get into that point a little bit later on. So we know, unfortunately, the survival rates for biliary tract cancer or cholangiocarcinomas, that's what CCA means, is poor. And whether you look at disease that's been resected versus unresectable disease or stage 4 disease, we're seeing the orders of years to months survival. So, we need, and if we do nothing, if we don't put them on treatment. So we need to find better ways to treat patients. What's really important in biliary tract cancer is coordination and communication with multidisciplinary teams. It is well known that you need to be having your interventionalists talking to the surgeons, talking to the pathologists, talking to medical oncologists, talking to gastroenterologists, because you need to constantly be talking about how to treat these patients. Can you cut it out with surgery? Can you target it with any kind of local treatments like TACE or TARE or microwave ablations or SBRT? Like, can you do stuff like that? Do you put them on treatment, then bring them back? So we're constantly bringing patients back to these tumor boards to say, I've done this so far. What are we doing next? Kind of thing. So let's talk about treatment of biliary tract cancer. So historically, way back in 1999, we had one treatment, and it was just IV chemotherapy called gemcitabine. And then for almost a decade, just over a decade, I guess, we just had that. And then subsequently, another trial came out that showed if you add a secondary chemo called cisplatin, it's much better than just the single agent gemcitabine, and that became the standard of care. Now, we historically always said all the cholangiomas are the same, so we treat them all the same, so they all got the same treatment. And then in 2023, this is when the idea of immunotherapy came around, 2022, 2023. We were using it more in lung, in melanoma, in our disease sites, but it eventually was like, can we use this in biliary tract cancer? And we had data published in 2023 that showed adding immunotherapy and durvalumab to the chemotherapy regimen improved things compared to just chemo alone. And then the next year, another immunotherapy drug, pembrolizumab, showed equal benefit with chemotherapy as the durva-cisgem. So now standard of care is adding immunotherapy with chemotherapy. But there has been lots of attempts to try to improve on just the plain backbone chemotherapy. Whether you try other chemotherapy drugs, adding different targeted drugs, unfortunately, they've all been negative studies. They haven't worked out at all. And which is a shame because you're always hoping for something better, but it's just clearly changing chemo, adding chemo, didn't add anything. The idea behind why is if you think about bile is very caustic and it's sitting in the bile duct, sitting in the gallbladder. So you have this caustic chemical sitting there. So the cells around it have to develop a mechanism to prevent it from being killed off or mutated by this bile. And so there's genes called the mechanism of chemoresistance in the biliary tract, which are expressed in these cholangiocytes, which protects the cells. The problem is chemotherapy is trying to do the same thing the bile is trying to do. Target cells, mutate the cells, kill the cells. But you have something, a mechanism in the cells that's trying to prevent that from happening. So it is probably the reason why chemotherapy doesn't work over a period of time, because the cells eventually figure out a way to block it from working as well. Which is why the idea of immunotherapy came out as let's try to add something else to the chemotherapy and see if that can overcome all this. And it did. So now we've done immunotherapy, we've talked about chemotherapy, so then can we change it up a bit? And this is where the idea of precision medicine comes out. And so, when I try to figure out definitions, I'm simple, so I go to Wikipedia. It works very well. So precision medicine is a medical model that proposes the customization of healthcare with medical decisions, treatments, practices, products being tailored to the individual patient. So in the model, a diagnostic test is often used to select the appropriate or optimal therapy based on something in the patient's genetic content or something molecular or cellular analysis. Okay, so what does that really mean though? Well, before we jump into that, I just want to say this is not a new idea. This has been around for a long time. The article on the left was something published in 2006. And these are screen captures of things that were published in 2015 and 2017. So this idea has been around for a long period of time. So what is it? So the way we practice medicine is we see a patient who has an issue and we give them a therapy. Some of those patients are going to benefit from the therapy. Some are going to have no benefit from the therapy. It just not going to work. And some are going to have some adverse events to the therapy you gave. The idea of precision medicine is you take the patient and you do some tests on them, and then you identify what therapy is going to work on them based on the test. So you're avoiding the no benefit component, and you're avoiding the adverse events to a certain extent component as well. We know there's some pretty good literature that we practice something called imprecise medicine. So this was a great article done back, it's now 10 years, geez, it's getting old, where they looked at the top 10 grossing drugs that are being prescribed in the US, and they wanted to figure out how many patients did you have to treat to get one person to respond to that drug. So, for example, Nexium, which is omeprazole, which is a lot of people are on for heartburn. You have to treat 25 people to get one person to respond. You think of Crestor for cholesterol. I think that's pretty much in the water these days because almost everyone's on some kind of cholesterol lowering pill. You have to treat 20 people to just get one person to respond. When they looked at the data, approximately 50% of patients do not respond to their prescription drugs. That's what I mean by it's imprecise medicine. We're giving medications that they're just not responding to. And so if we can figure out a way to find a drug that responds to, then we kind of waste this whole giving medications that just don't work. So again, I'm somewhat a simple guy. So think of your lawn. Okay, you have your beautiful lawn. You spend all this time manicuring it, cutting it, and this weed shows up. Okay. The problem with the weed is you don't like the weed, so you want to kill it. So you use, and there's the weed there, you use this weed killer, which is just general weed killer, and you spray. Problem is, it then nukes your whole lawn because it's a very general treatment of the weed as well. Now, think of it this way. That's like chemotherapy. You take cancer cells, you give a chemotherapy, which is a very general thing, and it's going to hit the cancer cells, but it's going to hit your whole body, and then it's going to nuke your body, which is why you get all the side effects from chemotherapy. Because that's really what happens when you get the side effects, is because your body is responding to the chemotherapy as well. So now let's go back. You've got your weed. Well, now you're trying to figure out what type of weed is it? Is it crabgrass? Is it moss? Is it poison ivy? And then you target it with the specific weed killer that's then going to get rid of the weed, but leave the rest of the body okay, or less the rest of your lawn okay. And that's the idea between precision medicine, targeting the specific thing while leaving everything else, hopefully, just as well. So it's kind of like this. Chemotherapy is a big nuke. Precision medicine is like a scalpel, getting at the specific thing as well. They both work. It's just that there's ramifications for everything you're doing. So precision medicine helps cancer patients because it not just helps with therapy selection, it also helps with your diagnosis of the patient, prognosis to figure out how things are going to go. It can determine cancer susceptibility, what are the chances you could develop cancer as well, and then also help open up clinical trials that are out there for patients. So this, I keep saying precision medicine. What is precision medicine really? It's so you've got the patient, and then they've had a biopsy of their mass and it came back as cancer. You can take a piece of tissue from that biopsy and then run it through what we call next generation sequencing machine, which is going to then compare, it's going to create this tumor profile, so a map of the mutations in that piece of tissue that's then going to compare to other cancer databases and identify potential genes that might have drugs targeting those genes that might open up other treatment options for that patient. As I mentioned, precision medicine is not new. It's been around for a long time. Back in 1977, when you think about breast cancer can be hormone receptor positive or negative, or the estrogen receptor, well known to be involved in breast cancer. That came the development of something called tamoxifen, which could target the estrogen receptor on breast cancer to help slow down the growth of cancer cells. So again, the idea is your breast cancer ER positive, estrogen receptor positive or negative? That is something like precision medicine, giving something very targeted to the breast cancer cells. So this has been around for a long time. It's not new. So when you think about all the drugs that are out there, there's a lot of drugs that are out there targeting very specific mutations in tumor cells. And this is just a small sample of what's out there. When you actually look at it, there's over 26 genes that have 60 targeted drugs, which is over, and now in 2024, there's over 100 drugs that are targeted specific genes themselves. So there's a lot out there. So the idea is changing the paradigm of how we treat patients. So as opposed to, well, you have a gastric cancer or a breast cancer, we treat them differently. Now we look at what is the genomic factors that are within the tissue and then look at that. So if both gastric and breast cancer are HER2 positive, well, we should probably be treating them very similarly because they're both HER2 positive. And so that's the change of how we're trying to look at things now. Problem with precision medicine is there's a lot of infrastructure that's required to do this. You need to have the personnel, so the expertise. So you need the researchers, the trialists, the bioinformaticians. These are the ones who read and try to help kind of take the information of the genes and matching it to the treatments. And then you need genetic counselors, because if you find a mutation, that you have to know what is that for you, what is that for your family. But then you also have to have the hardware, the DNA processing facility. You have to have the patients. You have to have the funding for it. So it's a lot to do, which is why it's not being done everywhere. So let's get back. I've kind of segued away from biliary tract cancer a little bit. So let's get back to why is precision medicine so important. So we know that historically we used to say intrahepatic is the same as extrahepatic, was the same as a gallbladder cancer. But we now know it's not true. We know that there's been studies that have mapped out mutation burdens in these intrahepatic, extrahepatic gallbladders, and they're different. So, for example, if you have an intrahepatic cholangiocarcinoma, you're much more likely to find like IDH1 mutations, KRAS mutations, whereas FGFRs can be found in intrahepatics, but not found in extrahepatics as much. Low in gallbladder, for example. Way more KRAS mutations in extrahepatics, for example. Way more HER2 implications in gallbladder cancers. So they're different. We've historically treated them the same, but they're actually really different. And so there's always the argument of, should we be treating them the same? Even within the intrahepatics, I mentioned there's mass forming and there's ones that are just flat against the ducts. They also have different genomics as well. So again, it's very important to figure out what the gene is for these tumors. So this is kind of the incidence, the NCCN, so National Comprehensive Cancer Network. They've published like what is the theoretical proximal incidence based on some of the data they've seen. And again, you're seeing less than 1% NTRK mutations, BRAF mutations up to 5%, FGFR up to 15%. They're small numbers, but when you add everything together, we're talking like 40, 50, 40% of patients having some kind of mutation that there's a drug out there for. So tissue. Tissue is the issue. You'll hear the physicians always say this is thing like, should I get a tissue biopsy? Absolutely, always get a tissue biopsy. You know, we need the tissue not only to help with the diagnosis, but you need the tissue to do the sequencing to do precision medicine. Without it, can't do it. So if you ever hear people chatter saying, should I get a piece of tissue? The answer is yes. Get the tissue. So I'm not going to go into all the trial data. I didn't want to go through all that. But you know what is important is there are studies that show that if you can match someone who has a mutation with their targeted drug for that mutation, they do better than if they just go on standard of care. So this is why we say, yes, you should always get your tissue sequenced because the outcome is usually better. It adds an extra next line of treatment for a patient that if you don't do it, we don't have it, and you're just stuck with chemotherapy. There are a lot of targeted treatments that are out there. This is just some of them that you see in the biliary tract world. But you can see there's quite a lot. Now, this is all what's available in the US. So we're a little more limited in Canada what we have access to at this point. So from Halifax, so let's talk a little bit about Halifax. So historically, we had this small little machine called the aluminum MyStack, and we could only run like 15 samples, and we did like 15 genes. Very small potatoes when it comes to things. But we knew where things were going. And so I keep saying we, not me. I helped, but it all goes to the Path Lab. We partner with the QE2 Foundation, the Ride for Cancer, and we were able to get funding to get a new machine that now could run at least 30 samples per run up to 500 genes, which allows us to actually do more. Now, the dream is that NovaSeq 6000, that's down the road, but yay, maybe, possibly. But that's where we would like to go. And that's where you can start running whole genomes, exome, transcriptomes, and learn a lot about the patient. And this is the new panel that we use, that we look at. We're one of the few places in Canada that actually have panels for patient care. Many others can do research-based stuff, but we can actually do this for patients to try to find, do they have a target mutation that we can get access to some kind of treatment out there. So since we've been able to do this, it is about January 2023, over 69 patients, 15 of them actually underwent testing, of which we found 10 out of the 15. So 2/3 of the patients had some kind of mutation that we could probably look at getting some kind of target treatment for, which is pretty impressive. Now, the question becomes, I said there's 69 patients, only 15 of them had testing, so what about the rest of them? Well, some of them are what we call adjuvant, so they've had surgery. We usually reserve the NGS testing for those who are metastatic or have progressed to low, like advanced disease as well. So people who have early disease, we don't really do it. Some patients, unfortunately, declined treatment or weren't strong enough to get on treatment. And we had patients who passed away, unfortunately. Sometimes we don't have tissue. It does happen. But as I mentioned, when you have those little brushings, the common bile ducts, it's very little tissue, and sometimes it's just not enough to do the testing as well. So for majority of the patients, there was a reason why we couldn't do the testing. But it does show if you identify the right patients, you get the testing, there's a good chance we might find something here. Now, the one thing I always talk about is the fact that I think the mutation burden is different. So if I mentioned Nova Scotia has a higher rate of biliary tract cancer compared to Ontario and BC, and I suspect, and we're starting to learn more, that each province probably has different mutational burdens compared to other provinces. And so therefore the incidence and outcomes of patients are going to differ across the different provinces. And it's now why we're doing a lot of research in the various different places to try to look at these genomic burdens of patients, because we suspect it's not the same. It's not the same as the US or anywhere else. So this is the treatment algorithm we have in Canada. And so in the first line setting, we give them chemotherapy plus immunotherapy, your choice of durvalumab, pembrolizumab, they're both approved. But we also suggest NGS molecular testing, so precision medicine testing, so that after the first line treatment, we have that information, and if they progress, we then have potentially, if they carry certain mutations, we can look at the targeted treatments that we have available for them. And of course, all comers, if they have no mutations, we can look at more chemotherapy as well. Now, this is not just me saying this. We have guidelines. So there's Canadian recommendations for biliary tract treatments. I will say I did help write this, so I am kind of saying that as well. But there's other places too. So we have the ESMO guidelines. So this is the European Society of Medical Oncology. They also recommend molecular profiling. You see here on the right, advanced metastatic disease, you do molecular profiling, give them the chemotherapy, immunotherapy treatment, and then second line, same thing. They have a targeted mutation, try to get them access to that targeted treatment as well. As I mentioned, the NCCN, the National Comprehensive Cancer Network, again, their guidelines as well as American suggest NGS testing in the first line and then subsequent lines looking at their mutation and see if we can get access to things there. So, what are some of the biggest hurdles when we talk about this is costs. So who pays for testing? So there's a great pathway for a brand new drug comes into Canada, gets approved and covered by Canada. But if there's a test associated with that, that test actually doesn't get covered. So somehow, some way, someone has to pay for that test. And so can pathology labs cover those budgets? It's hard to say, because as more and more things come with testing, you have to fit them in the budgets. How do you access the drugs? Because again, the problem with some of these precision medicine is there's not a lot of trials that provides the evidence. There's a lot of case reports sometimes. There might be early stage trials, but there's no phase 3 trials because you're not going to have 1,000 patients with that mutation. It's going to be really hard to find. You'd have to open across the world and you have to be running for many, many years. So you're not going to find it. So usually it's smaller volume studies, and it's harder right now for CDA to understand these trials because it's just something different than what they used to do. And so getting access through the normal pathways is more difficult. So then you have to look at, are there trials with that study, with that disease, with that mutation, with that drug that you can get on? Can you get compassionate access from the pharmaceutical company, or do you pay for it yourself? I mean, these are things that we have to have these conversations about with patients. And then again, to do NGS testing, I mentioned there's a lot of infrastructure that needs to be involved. Do you have the technologists? Do you have the bioinformatics to do all the work? And a lot of places don't, which is partly why this is not being done everywhere. So I just mentioned things about algorithms. And so you can see the Canadian algorithm I showed, the ESMO algorithm. So, but where's the evidence that comes to generate these algorithms? And really, it's from clinical trials. These algorithms are purely based on clinical trial data. So then just bear with me for a moment. So a clinical trial is a research study involving human participants that evaluates the safety or the effects of one or more interventions in the health outcomes. The interventions are not necessarily drugs. They can be, but they can be vaccines, radiopharmaceuticals, biologics, surgery procedures, radiologic procedures. It's just anything you want to test to see if it works or what the outcomes are as well. And then the data used on the trials are used for approval of the drugs and help to develop these algorithms as well. We run oncology trials because it helps determine whether a new treatment is going to be safe and effective and work better than the current treatment, to determine whether a new treatment has less harmful side effects than standard treatment, and to provide access for patients as well. As I say, sometimes these drugs we don't have access to, but we might through a clinical trial. So you'll hear things like phase of trials. So when we do a trial, there's the first phase, which is where you're trying to find, is the medicine or intervention really safe? And so you're taking healthy individuals and giving them the treatment to see, does it work? The next phase is phase 2, and that's just looking at a larger population. Does it work? What's the side effects? And what's the safest, most effective dose too? It's when it's the phase 3, that's when you have a large population of patients. And now you're looking at what are the outcomes from the treatment and then what are side effects. Phase 4 is when the drug's already approved, and now you're looking at the whole community population to see what's happening in the real world as well. But this can take up to 15 years to go from the explorative research to the phase 3 where the things are getting approved. So it takes a long time for these things to percolate up the system. So the reason why I talk about this is these are all the trials that are going on as of 3 years ago, which are looking at targeted treatments and advanced BTC. There's a lot of trials that are out there in the world, not necessarily in Canada, but in the world, that are looking at particular targeted mutations in biliary tract cancer. And so this is why it's important to do this kind of testing, because then you want to see, can I find something out there in the world that might be applicable to me? So I just said, are they applicable to me? Well, so here's one of the caveats I always want to throw out to people. Because are these trial results applicable to you? So one of the problems with a lot of research historically is the population you're doing the testing on. So this is a great example. The Cancer Genome Atlas program, an amazing program that was a landmark cancer genomics program. They characterized over 20,000 cancers and matched it to normal samples to try to figure out more information about it. But when you dive into it, there's little information on minorities or different racial and ethnic groups. And you can see the breakdown there that 77% were Caucasian. 12% were, at this point, African American. It's even less of the other. So, if I'm sitting in front of you and I'm a patient and I'm saying, what is my mutation burden? I don't know, because there's no data to tell us what it is. So we're basing it on these programs that may not be applicable to me. or to the patient in front of you because they're from a different ethnic group as well. So when I talk to patients, I say, this is the ballpark percentage, but I don't know. We don't know. And this is why we do the test, because even if they say it's a 1% chance, you want to do the test because the answer is either yes or no. So it's either 100 or 0, in my opinion. So always do the test. Okay, so just a couple little plugs before we finish, and this should give us a couple minutes to answer any questions. So, can you get testing? Some places do testing. We do it, for example, in Nova Scotia. But if you don't have access to testing at your center, you can go through the Canadian Cholangiocarcinoma Collaborative, which has access to testing. And so outside of Quebec, there's a different way, but in Ontario, they do testing at UHN. The rest of Canada, they send the testing out to OncoHelix, which is in Calgary. And so you can get your tumor tested through their program for free. So it's just a matter of giving a little bit of information to get access to this. So if you're at a site that doesn't do the testing, this is a mechanism to get access to your testing. And again, if you're always wondering, like say, I've done my test, I know my molecular profile, well, you can also look for, is there trials for you? And so clinicaltrials.gov, any clinical trial in North America has to be registered through this portal. And so you can search cholangiocarcinoma, KRAS mutation, and it'll pull up all the trials, and then you can kind of select out to what are actively recruiting or will be recruiting shortly, as opposed to what's closed as well. So just to summarize, biliary tract cancers, they're not rare. Okay, I think historically everyone used to say they're very rare, but reality is we think it's not as rare as we think it is. But we need more national data to really understand what is not rare or rare there. We're seeing systemic treatments and precision medicine. It's improving. We're seeing the outcomes improve. And you get those cases like I presented earlier where they were stage 4 and they're still stage 4, but I have no evidence of cancer on the imaging scan. We're just kind of following them and see what happens. And wow, we need more trials. We need more studies to put patients on and to see how we can improve things as well. So with that, I'm going to stop there, and I think there might be some questions, and I'm happy to answer them.
No, great talk. Okay, so the first one is, do you think there'll be any tests for early diagnosis for cholangiocarcinoma, especially for patients without any real risk factors?
Yeah, so theoretically, this is, I think, where liquid biopsy is starting to kind of talk about. So the idea of screening people with liquid biopsies, which have certain risk factors as well. But that's really in the infancy. I think right now, liquid biopsy, what they're trying to use now is say you've had your tumor removed and you're trying to decide, should I give you treatment, chemo, whatever, after your surgery, or can I spare you that? One of the things is, hey, can I do this with liquid biopsy and see, do I see cancer cells flowing in your body? If there is, maybe we should need to put you on what we call adjuvant treatment versus there's nothing there. Let's just watch you. So I think that's kind of where liquid biopsy is going. But there are talks about studies that look at what about screening as well. But there's implications of the screening too, because there are such things as false positives. So you do a test and you comes back positive, and then it leads to more testing and more further testing, and then there's anxiety with all that. But eventually it's found out, no, actually it was a false. It wasn't actually true. So there is that component that everyone is worried about when we think about testing. And also, what happens if you do the test, it's negative, but actually it was positive. It should have been positive. There are false negatives to a testing. So this is why they're doing the work to try to figure that out, but it's really in the infancy. We're not there yet. Second component to that is the CA19-9, because people always ask, why aren't we doing CA19-9s on everyone? The reality is a CA19-9 can go up with anything that affects the biliary tract. So you can have an infection, inflammation, you have a stone, you can have cancer, anything can cause that. There's also about 15% of people that don't express the molecules to create the CA19-9. And so, we see it all the time. You have a cancer diagnosis, pathologically confirmed, you had a biopsy, but the CA19-9 is normal. So it's not a great test. It's a good test where it's high you cut it out and it goes low, or it's high, you put them on treatment, it goes low, or if it starts going up, you see changes on the CT scan. So it's something like that where you can track. But it's not a good test in a population setting because there's a higher rate of false positives and false negatives with that.
So there is a question on liquid biopsies. Are liquid biopsies okay to do for patients that don't have tissue biopsies?
That's
They're
something
kind of answered.
that's actually where a lot of people want to go to is can we oops, let's not restart the computer yet.
Was that you? Okay.
That was me. It's been trying to restart all day. Uh, so the idea of liquid biopsy is it's an easier way of tracking things. What can you use it for people who you can't get a biopsy? So, for example, as I mentioned, those perihilar tumors, they sit underneath the liver. They're not easy to get at with a needle. Sure, you can do it surgically, but that's a lot to do to a patient. So the idea is, can we use a liquid biopsy as a means of diagnosis and also do molecular testing on that? But it's still a little new. In biliary tract, we're not there yet. They're just working on the lung side of things. That's probably where it's going to come first. And then I think lung, then breast cancer, and then the other GI cancers after that is kind of where. But it takes a while to get the evidence to tell us we can trust it. But that's where we're hopefully heading to, knock on wood.
Do you think pan-tumor trials will be possible in the future for cholangiocarcinoma patients? Because you mentioned there's not very many enough patients for phase threes, and so will we see that?
So there are studies called basket studies. So there's like a study which has, if you have mutation KRAS, you can get on this drug. If you have HER2 positivity, you have this drug. So there are trials and it looks at all disease sites or many disease sites, sorry, that are, they're called a basket study as well, or umbrella studies is another term for it. So they are out there, but they're not common. And it's a little, so they tend to be more what we call academic studies. So they're led by investigators like physicians or whatnot. They're not as common in industry because usually one company has one drug, one company has another drug. So to do a basket study, you need to have multiple companies providing the drugs for those studies. And so that's where the academic side, because they'll kind of interact with all these companies to get the drugs coming in, but you won't have one company sponsoring a full kind of panel because they just don't have the panel of drugs to do that.
Okay, and the last question I have here is some specialists in cholangiocarcinoma are beginning to believe that combining multiple therapies may improve, oh, too bad question, sorry, may improve outcomes. For instance, using both immunotherapy and precision medicine together. Do you have any thoughts on this?
Yeah, so right now we don't have the data to support it per se. Um, there is thoughts about it. I guess the right now the idea is you have chemoimmunotherapy. If you have target treatment, that's the next line, and then another chemotherapy. If you combine it all into one, the positive side is potentially for one particular patient, that combination works extremely well. But for another patient, it doesn't work that well. And all of a sudden now, what you may have had for multiple lines of treatment, you've now combined everything into one and you have nothing left. So there is that aspect to it. There are studies adding targeted treatments with chemoimmunotherapy versus chemoimmunotherapy. So there are studies looking at this right now. But I don't think we have the data yet to say this is the way we should be doing it.
If they did that targeted therapy with the chemo immunotherapy, would they, like sometimes now when they finish their chemotherapy for 8 weeks and they put them on immunotherapy alone for 4 months, do you think they might do that with the targeted therapy for 4 months, or would that sort of have to be a trial?
It'd be a trial. You
Yeah.
need to have the evidence to support taking them off the chemo. Sometimes chemotherapy works synergistically with some of these targeted treatments. Sometimes they don't. So you need to kind of see how it works to determine should you be taking them off or keep it going as well.
I have another question. Is the solution to have more pan-tumor basket trials or to pursue expanding indication of drugs that are currently approved for other disease site?
Yeah.
Um,
So
I don't-
it's a great question that we keep talking to each other about. Well, not each, we talk with the government about because, the government would like to see more studies to really truly prove that this works. But the idea is, and I mentioned it before, if you have evidence in breast cancer that shows HER2 positive treatment works, why do you need to then do another trial in gastric cancer that's HER2 positive? If you already know it works on one disease side, why can't you just extrapolate to the other disease site? Um, that's how some of us think, but that's not the way the drugs are funded. And so you need the evidence to get the government to fund the treatment in order for you to use it. So we can't prescribe things that are not funded. We just can't. So not because we don't want to, it's because we literally cannot do that. So you need to have it approved in order to access the treatment, in order to prescribe it.
We need to be asking the drug companies to go back and doing some expanding their trial to include those other diseases, I guess.
Yeah, I mean, that is one way definitely to do it. But I mean, the argument also is if you have enough evidence out there on other disease sites, like to do it in a rare tumor, it doesn't make logical sense. It makes more sense to just apply the evidence from other disease sites and bring it to this disease site. But I will say there has been times where they've done that in the past, and then it turns out it doesn't work because they do a study and it turns out that treatment actually doesn't work in that disease site, which is where the hesitation comes from because there has been historics where they've done that and it actually did work as well.
I have one more question. Do you feel the testing offered by I have two more questions. UHN and OncoHelix is comprehensive enough for biliary tract cancer? Should patients look at pursuing more advanced testing if they do not find targetable mutations on their initial test? Good question.
It's a great question. No, I do think their testing is highly applicable because there's only so many targeted drugs out there too. So, and all their panels cover all the targeted drugs. So, I mean, all the other stuff is, future potential kind of thing. There might be a drug 10 years from now that targets a mutation we didn't know about. But as you remember, I mentioned that for trials, it can be 15, 20 years from when they start the whole basic science research to get to studies. So it can be a long period of time for those drugs to come to the market. Those panels cover everything that we have access to now and the ones that are probably in the trials at the moment. There are other molecular testing, which I don't want to say is comprehensive, but more comprehensive, but has like a little bit of extra stuff. But that's just more research-based stuff than anything else. It won't affect what's available for a patient.
And what are your recommendation or what are your recommended next steps for a patient that did biomarker testing with resulting returned as no reportable variants due to lack of tumor in specimens collected during biopsy? What would you recommend their next step be?
Yeah, yeah, because that happens. Um, sometimes they go in and they go from the outside to the liver. They think they hit the tumor and they miss. That happens sometimes. Or they get a CBD brushing and that didn't give enough tumor. I have a conversation with the patient about whether they want to go through it again. One of the problems with biopsies is there's always a risk of bleeding and infection with everything. There's always a potential. Doesn't happen often, but it's still a risk. And it's not the most comfortable procedure in the world, too. So I will have that conversation with the patient and say, you know what, we attempted to get a biopsy and it came back negative, or like we didn't have enough tissue to do the testing. Um, do you want to try again? Sometimes I put them on treatment, see how things go, and then bring back the idea of going back for a biopsy as well. And some patients choose not to, but it's part of that conversation about do we do this again or not? Because again, we could do it again and still get no tissue. That can happen as well.
So would you recommend a liquid biopsy, or the other question too is if you go and rebiopsy, is there an increased chance of spreading the cancer, like with the?
Yeah, so liquid biopsy is not available really
Okay,
right now for biliary tract cancer because there's just not enough
okay,
evidence to tell us if you do it that we'll get an answer from it. The idea of spread. So this was something a long time ago where if you went in, there's some cancers that are kind of cystic, very fluid filled, and you go in and put a needle in and it might spray it out. But reality is most do not spread that way when you do a biopsy as well. The way they do the methods of things, the chances of reseeding the tract is extremely low. It's not zero, but it's extremely low.
all right. I don't have any more questions. Should we just wait a second while we see if anybody has any more questions? In the meantime, I will thank you. So thank you very much for such an informative presentation. You answered many questions that patients and caregivers have about precision medicine and its role with biliary tract cancer. You've inspired hope, and I really thank you. And in the chat box, they're all saying thank you as well.
Well,
So
thank you
we
for
really
having me.
appreciate you taking your time. Yes,
Anytime.
thank you.